to the presentation on pediatric orthopedics. This is actually a very complex subject, so I can just tell you the basics today. And one example will be DDH, a developmental dysplasia of the hip. Pediatric orthopedics is about the prevention and treatment of musculoskeletal disorders in children. And a lot about it will be about prevention. I'll tell you more about that later. This is just a short overview. As I just said, there are many specific diseases to be considered in pediatric orthopedics. The main difference to adults is, of course, obviously growth. Kids are growing. This is why they are still called kids. So there's both the possibility of spontaneous correction of deformities and the possibility of worsening a defect due to growth. So many fractures that need surgery in adults can be treated without surgery in children. You can accept a lot of this deformity in a 4, 5, 6-year-old fracture with much more than you can do in adults. If you look again after the kid 2, 3 years down the line, the deformity will be gone, especially in the upper extremities. But some conditions should be treated as early as possible to get a good result, because growth will just make the problem worse and worse. And it's easier, the treatment is easier to treat if you start treatment early. So what is growth? So joint deforms out of condensation of mesenchyme. Then there comes cartilage formation with a synovium around it, and the cavity just forms later, and the secondary ossification centers also come later. This joint formation requires motion. So if a kid cannot move correctly, does not have a functioning neuromuscular system, this leads to defective joints. They are often seen in children with neurological problems, cerebral palsy or polio, for example. This is basically the same again. The bone formation, mesenchymal cells condense to become models for future bones. When there's the chondrification, and this cartilage is later converted to bone by intramembranous and endochondral ossification. I hope you studied all that in the beginning of your medical studies, so I'm not going into that. There's primary ossification centers and secondary ossification centers. So this is what that looks like. Mesenchyme replaced by cartilage, replaced by bone in the middle, blood vessels growing into it, secondary ossification centers with blood vessels going into it, and this is what it looks like later. This is just a typical lung ball. So this is just a quick example of what can go wrong. This picture is an excerpt for this one. So this is the growth plate. Looked at histologically. This is what it looks like under the microscope. This is what the zone is called like. This is where which disease can turn up in which zone. And this is the mechanism. You don't have to study all that, but you see it's pretty complicated. So, for example, rickets, which is the calcium or vitamin D deficiency, goes into this zone and makes deformity at this level. Osteomyelitis here is still in the metaphysis, just on the lower end here. So this is just an overview. You might have to study that in detail later on, but today is not much help. So this is great. So obviously the biggest growth occurs at the beginning. A child is usually born with 50 centimeters, and in the first year they grow at about 20-25 centimeters. So at 1 year of age, they're already 75 centimeters. But the growth rate declines until they have the growth spurt at pre-puberty. Earlier for girls, later for boys. So this is on another plot. This is the size in centimeters and the years of age. See? And sometime here they stop growing at about 16 for girls, a little bit later for boys. This example from my household, I usually make the kids, I made them stand against the wall and mark against the wall how they were growing. So this actually is my son. And you can see from 11 to 12 to 13, he was already a bit more. And from 13 to 14, he was growing really a lot. To 15, it slowed down. 16, not much. Now he's 20 and he's nothing much here. Same for my girl from 11 to 12, quite some, to 13, quite some, to 14, and now slowing down and not much. This is actually good fun for if you have kids. The kids really like that. So this is a couple of things that might they have effect rates. So some accelerate and some retard growth. Huh? So this is just a overview to look up if you want to know that. So different factors have different effects on the growth plate. Physical compression retards, ischemic injury retards, fracture might accelerate, and of course we have the receding. I'll show you examples later on. So another important point in orthopedic, pediatric orthopedics is how tall is a person going to get? So what you need for this is first you need the bone age. I'll tell you how to get the bone age of a person, usually by taking an X-ray of the left wrist, comparing it with an atlas. More about that later. So you have your bone age of a boy. This is the chart for boys. And you put a red line down here. And how tall is he right now? This is unfortunately in inches. You have to calculate that. Reverse that into meter and centimeters. And then you pull a line over here, and then you follow this growth line, and then you will know how tall this boy is probably going to be. This is an estimation. It's not really true science. It is science, but still there's some other factors that prevent him growing. You will need that for the timing of when to correct what deformity. Here, this is again how to get the bone age. That's estimating the bone age of a living child is typically performed by comparing X-ray images of their bones to images of models of the average skeleton for a given age and sex acquired from healthy children and compiled in an atlas. The features of bone development include the presence of bones. I'll show you later on. Have certain bones ossified yet? The size and shape of bones, the amount of mineralization, also called ossification, and the degree of fusion between the epiphysis and the metaphysis. Usually, the left hand is used for that. In the United States, bone age is usually determined by comparing an X-ray of the patient's left hand and wrist to a set of reference images contained in the Grölich and Pyle Atlas. This atlas was compiled, I think, in the 50s and 60s, and is all of white children living in the area where those guys were working. So it does not help, it does not include samples of people of color or Asian community. So it's helpful for white people, but we don't really know how we can compare them to people of color. There are no new methods, including using AI, artificial intelligence. So when you do that in pediatric orthopedics in 5 years' time, you will probably be using artificial intelligence. So those are X-ray films of kids of different age. Here you can see what I said. This is a boy, 3.5 years old. There are several bones. As you know, you should have 8 bones here and the carpal bones. And there's just 4 visible here, 5 maybe. If you compare that with the boy 14 years, of course you can see them all. Here, the epiphysis of the ulna, distal ulna, is not preformed. Here it's present. Here some you can see what is ossified already, what is not there, and this is an atlas they have. Boy, 3 years, 2 months, 3 years, 6 months, 3 years, 8 months, whatever, and you compare that to an up-to-date X-ray of the kid you are doing right now. Another sign of guessing the bone age or estimating the bone age is the so-called Risser sign. You take an X-ray of the pelvis, of the pelvic bone, and depending on the ossification here of the rim of the iliac apophysis, we can see from Risser 0, 1, 2, 3, 4, 5. Here all is there, the apophysis is there, and for Risser 5 it's fully fused. You have that usually on X-rays of the spine. So if you have a kid to be treated for scoliosis, you will have the pelvis on the X-ray film anyway, and then you can guess the skeletal maturity. You will need that in scoliosis because scoliosis gets worse during growth and stops getting worse when growth stops. So you need to estimate how bad is it now, how bad is it going to get, do I have to do something, and when. So pediatric orthopedic problems can arise from several things. First, they can arise from genetic factors, dominant or recessive or X chromosome linked or polygenic. They can arise from intrauterine factors, teratogenic, mommy was smoking, for example, or mechanical. Maybe the umbilical cord was wrapped around extremities, for example. There might be metabolic or disorders like rickets, a neuromuscular deformity, for example, polio or cerebral palsy. There are inflammatory diseases, septic arthritis, which I was already talking about. And there's also juvenile rheumatoid arthritis. It's not very common, but it does happen on and off. It can start as early as 1.5 or 2 years old with joint swelling. Then, of course, there's trauma. There's physical activity and overuse. A lot of boys doing very much into sports, football, training every day, and overuse things might happen to them. And there's idiopathic developmental disorders. This is, one of the specialties of pediatric orthopedics to treat those. So what is the evaluation? What you need to look for? The presenting complaint usually is one of the following. It's either deformity. The parents present their kid, look how his leg likes, he's walking indoor, like with the internal rotation of the foot, or he has flat feet. So they're complaining about deformity. They're complaining about altered function. Something is not really working. And of course, they're complaining about pain. So the point is, take a thorough history and keep an open mind. Sometimes kids do things they probably should not do. So they are not telling you about the trauma because they climbed up a wall which was forbidden to them, and then they're probably not telling. But you should always take mother's intuition seriously. If mom brings her kid to the doctor and says something's wrong with the boy, with the girl, do take her seriously, and they may be right. And if you don't find anything, search again. Tell her to come back later. Maybe after, if you're really convinced this is harmless, tell her to come back in a few weeks' time to reassess. So this is from my textbook, a really sad case of misrepresenting their history. This was a boy who presented with a trauma history. 12-year-old boy gives a history of knee trauma and pain. This X-ray was considered to be normal, which of course it isn't. This is very clearly and easily to see a problem. 1 month later already, the lesion looked like that. And then this was diagnosed as Osgood-Schlatter, which of course looks completely different. 2 months later, you see half the bone is gone. And then just before his death, they took an X-ray of the chest, and this is really catastrophe. This is the primary age group, 10, 12, 14-year-old boy with history with the knee pain. Of course, all kids fall on and off, so don't get distracted by this history of trauma. The question to ask in this is, does it hurt at nighttime? Tumors hurt at nighttime. So this is even with trauma history, yeah, just keep an open mind about other problems as well. So deformity, most often it's a rotational problem, flat feet or bow legs. And in this case, have a look at the parents. If they have the same condition, it will very likely persist. It's very hard to fight against genetics. And if it's something which is not really harmful, tell them this is not really a bad problem and can happily be ignored. But grandma has the same. Yes, one more reason not to do anything, because I can't change genetics. And not everything doesn't look like everybody else's is really pathologic. Don't miss congenital or neuromuscular deformities. And as obvious, ask about onset, progression, and about previous treatment, what has been done already. Another complaint, altered function. Altered function may be due to pain in toddlers and the newborn. For example, a clavicular fracture during birth. You will see loss of arm movement. It's called a pseudo-paralysis. So he will not know that he is in pain, because newborns are sometimes crying because they're hungry and sometimes crying because they have pain. And if this is, for example, a first mom, she probably won't be able to tell the two apart. And also, if the child is not moving, then probably it's not hurting. So it's just he just learns babies are not stupid. If I don't move my arm, it's not hurting. So the mom will come loss of arm movement. So also a specialty of pediatric orthopedics, sometimes repeated examination and investigation may be needed. A timeline, a so-called timeline, to see if a condition gets better or worse. Here, this is a remodel, a lovely example of childhood remodeling. This was a fracture here. You can't really see it on this picture, but if you look at that one, here you see the deformity. This was a gross deformity. Physeal fracture was malunion at 12 months old. This was 1 year later. Here it looks okay. This hip looks exactly like the other one, like nearly exactly like the other one. And if you have a look at the picture, that's fine. You can accept that. So here, if you just see this picture, you say, oh my goodness, we have to do this, 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 this. Well, I mean, yeah, it's remodeled itself, nothing to be done. And if this child is 12, 15, you probably won't know any difference. Here, the other example, these radiographs show the effect of time and growth when a physeal bridge is present. This is a bridge across the growth plate. So here, usually due to an injury or sometimes meningococcal infection can do that. So here, this was not growing. This side here is growing. So this is growing, this is not growing. So this is really a nasty, nasty, nasty deformity. So what you could do is arrest growth on the other side to do a hemiepiphysiodesis. But then you need to calculate how much growth is left. So this is why you need the growth charts before. Yeah, this is why I showed you this before. You have to calculate how much growth is left. Does the deformity look here? 2 years later, it looks like that. This boy is a 12-year-old. He will, as I showed you, have some more growth left. So you have to calculate that and calculate when to do what surgery. So some common problems are syndromes, for example, Down syndrome. Down syndrome, kids who have that, they have many specific orthopedic problems as well, on the cervical spine, for example, and some other problems. Then there are neuromuscular disorders, for example, cerebral palsy or polio that you have to, this is pretty common. Tumors. Typical for osteosarcoma is pain at night, and this very often located at the knee joint. Half of the cases of osteosarcoma are at the knee joint. So this is a do not miss lesion. pain at night in a pre-puberty child, do take it serious, take an X-ray, have a high index of suspicion. Infections in kids, especially very young infants, septic and arthritis, osteomyelitis, or also tuberculosis in areas where this is a problem. So now I show you a list of specific problems and diseases at typical locations. This list is not complete, but if you know all those problems, then you have a good basis to start in pediatric orthopedics. So the most common problems in the spine are first spondylolysis and spondylolisthesis. Spondylolysis is there is a deformity of the lower lumbar vertebra, and this leads to a sliding of the vertebra on over the lower vertebra. This is very commonly seen in gymnasts. Kids should start doing gymnastics at a very young age. Here in Germany, we have very ambitious parents, mothers, so they send their kids to gymnastics at age 3, 4, 5, and they are doing the training 3, 4, 5 times per week. And this is one of the sequelae what might happen before that. Then there's Scheuermann disease, which is also pretty common. This is a disease mostly of the thoracic spine, leads to a kyphotic deformity. This is actually also pretty common. And there is scoliosis, which is a deformity of the spine in the second sagittal plane. No, in the other planes. This is sagittal and this is the other ones. So you have either idiopathic, congenital, or neuromuscular scoliosis. This is also pretty common. The most common about those is idiopathic scoliosis, which is usually discovered in kids about the pre-puberty. It does not hurt. They don't complain of any pain. Just somebody sees them in their swimming pool and says, "Wow, you're looking a bit crooked." This is also a chapter by itself. I can talk about that if somebody wants that. So a hip joint. Many hip problems of adults have their origin during the growth phase. So it's very helpful to treat hip problems of kids correct and completely as to prevent adults from having osteoarthritis of the hip joint. And so early treatment in infancy may prevent later problems, not only may, but usually does prevent later problems. Osteoarthritis due to the deformity. So the most common problem of the hip joint are DDH, developmental dysplasia of the hip, LCP disease, leg calvé purchase disease, which usually affects primary school kids age 5 to 8, 9. And there's slipped capital femoral epiphysis or SUFI, slipped upper femoral epiphysis, which is exactly what it says, that the capital femoral epiphysis is slipping and making a deformity. This is actually in pre-puberty kids. This is very common. Those kids are older than the LCP kids. And then very common, there's toxic or transient synovitis. I already spoke about that when I spoke about septic. Pretty common. So on the knee joint, the common problem is Osgood-Schlatter disease. This is a inflammation of the apophysis of the patellar tendon. Insertion of patellar tendon is this most likely to overuse in football players. It's pretty common. Treatment is just rest, which kids don't want to accept. Then there's osteochondritis dissecans on the knee joint, not rare, and very, very common is patellofemoral disorders. This is especially common with adolescent girls. So on the foot, sprains, of course, are very common due to sports and football and all kinds of things. Then there's also osteochondritis. They're called Köhler and Freiberg's disease. They're not that common, but you see them on and off. There's forefoot adductus, which looks like a sickle. It's also called sickle foot. And there's clubfoot. It's a deformity which kids are born with, and you see that like immediately after birth. Needs to be treated really on like second day of their life, better on the first day of their life. And there's Cavus deformity. and also osteochondritis dissecans of the talus, which is also a not so rare problem. On the upper limb, there's neonatal brachial plexus palsy, habitual shoulder dislocation, and another common problem is wrist pain, especially on adolescent girls. They are going to school, they're writing a lot, writing, and no reason can be found, whatever tests you do. It will that will go away itself after 2-3 years. So if you have a high a country where there's a lot of medical service, so parents will go from one doctor to the other, will have one MRI scan after the other one, will have arthroscopy of the wrist, and nothing will help whatsoever. It's a leave me alone lesion after 2-3 years, especially if you don't find anything on one MRI scan. Leave it be. That will go away by itself. So now I'm coming to the second topic of my presentation today. This is developmental dysplasia of the hip. This is actually one of my favorite topics because by early intervention, you can do so much and help the kids so much. It's so rewarding to treat those kids. It's by the definition of developmental DDH is it's a spectrum of anatomic abnormalities of the hip, ranging from mild dysplasia, that means anomaly of the acetabulum, to a complete high dislocation. So anything may be there. So what are the causes? So most likely, the most are idiopathic. There's neurologic condition. As I told you, joints need correct motion to grow. So if this is not pushed in here by growth, by movement, then another joint will develop up here. Or what also can happen after a prolonged effusion in the joint, the fluid in here is pushing the femoral head outside. So the acetabulum cannot really develop normally. Most cases are idiopathic. Parents might have had that. So this is the most common type here in Germany, at least. So again, idiopathic developmental DDH is an ossification disorder of the acetabulum. So the acetabulum is too steep to contain the femoral head. There's a varying severity, and it can lead to the hip dislocation to the cranial side. In 40% of the cases, it's bilaterally. It's 0.1% of births. So it's not very rare. It's pretty common. I don't know about Afghanistan. It's a pretty common condition here in Germany. It's often accompanied by other malformation, especially a club foot. So if the kid has a club foot, you definitely need to have a look at the hips. So the risk factors, it's a genetic condition. Girls to boys, it's 6-to-1 the ratio. There's a familial clustering, and breech presentation is a major risk factor. So if there has been a breech presentation, the hips definitely need to be examined. So what are the consequences? In case of, if you just have a minor dysplasia, degenerative coxarthritis will develop due to the lack of congruence of the joint partners. And it is thought that half of the women who develop degenerative arthritis have a pre-existing acetabular dysplasia. So that means by treating those kids, you can save half of the women from a hip joint replacement. So I think that's really very rewarding. Signs and symptoms, very, very hard to assess, especially in the newborn. If you have a dislocation, you might possibly see a leg length discrepancy. You might see a fold asymmetry in the case of luxation. And sometimes, possibly, I'll show you more about that, audible and palpable snapping of the femoral head, the ortolani sign, or there may be restricted mobility. If the kids start walking, there may be a shortening limb at walking age, but only if you have a real dislocation, not if you have just a mild dysplasia. So those are some X-ray pictures, which I copied from the internet. So this is a pretty normal picture of the normal hip joint. Here, this is a very normal, yeah, and here you can see this is an adult who has the acetabular roof does not cover the femoral head like here. Here, see half, that's it, it's the edge, it's the end, and the hip joint is still out, the femoral head is still here. So this leads to more pressure here and the asymmetry, and you have a nicely developed joint space here, but not here. And it's the same on the other side. You can see this is a bilateral condition. This is a normal hip joint, and this is pathologic. And this leads to osteoarthritis. Here also you can see the muscles here. Yeah, here this is a milder case. This is not as bad as this here, but this doesn't look as nice as this here. And this might still lead to early osteoarthritis. So this is just about the factors, how they increase the risk here. Positive family history increases the risk tenfold. Breech presentation increases the risk 5 to 10-fold. Torticollis is an associated deformity. Foot deformities, they make you think about intrauterine constraint, which is also like breech presentation, as I told you, a risk factor. Knee deformation are associated with a teratogenic type of dislocation. So this is what is the functional disability and the pain at what age. So if you have a complete high dislocation, this does not cause any pain at the beginning, just pain starts later and is actually not that bad. You just see the deformity. I'll show you pictures later on. If you have a dysplasia and subluxation, you have no functional disability or much less functional disability, but the hip, the pain starts early and leads to hip joint replacement already at the age of 40, maybe even earlier. And if you have a simple dysplasia, that does not lead to any functional disability, but depending on, as I showed you, how the grade of dysplasia leads to pain and hip joint replacement sooner or later. So those are the examination tests for newborn, how to examine them. It's the Barlow sign and the Ortolani sign. You move the leg of the baby, and then you can dislocate the hip posteriorly. And here it's the same with just another method. There's not a major difference between those two tests. The problem is they're only working if you have a complete dislocation. If you can dislocate the hip, if you can't, and you just have dislocation, dysplasia, then those tests will be negative, and you will think the kid is fine. Also, those tests are not very reliable. Easy to miss. Here, this kid has limited abduction. You can't abduct the hip joint. And here you see the leg length discrepancy. This is a shortening of this leg because it's further back. The hip joint, the femoral head is further back, which leads to the leg length discrepancy. Here, this is a kid which has bilateral DDH, complete dislocation, and you see the hyperlordosis because the femoral heads are not down here where they should be, they are up here, and they're forming a kind of knee arthrosis. There's a new joint which is forming about up here. So this kid can walk, probably painless, but it will develop back pain due to the hyperlordosis. This is very, very difficult to treat once it's reached this stage. It's very, very hard to do anything about it. The clinical tests are very unreliable, even in skilled examiners. Even if we have done that for years, it's still very easy to miss it. And as I said, a simple dysplasia cannot be detected with those clinical tests. And the next problem, interpretation of X-rays up to 3 to 6 months is very unreliable, as the ossification in the femoral head only develops at this stage. So you will only see a secondary ossification center in the femoral head at 3 to 6 months of age. So what's the solution to this problem? Use ultrasound. Ultrasound is a very, very, very reliable technique, but it needs to be performed with a standardized technique. So unfortunately, this is not used in English-speaking countries, and to be honest, I simply don't understand why. There was a guy from Austria named Graf, and he developed a very standardized technique with really very, very good results. And the English somehow, don't know, too stubborn, they didn't copy that. They developed their own technique, which is not as standardized and does not give reliable results. So if you see a study about ultrasound and DDH, you need to check which technique was used. Ultrasound does not equal ultrasound. So in Germany, every newborn is investigated with ultrasound at 6 weeks of age. And we have nearly no surgical treatment for idiopathic DDH. To be honest, kids who have neuromuscular disorders, of course, they still get it. But nearly no surgical treatment for idiopathic needed, because the prognosis is much better the sooner treatment is started. I had examined both my kids at much earlier than that. Newborns, 1-2 weeks, have an ultrasound test, and I will show you more about that later. So if anybody of you should be interested, the book of this fellow who developed the German method is available in English language. It's on the sources later on. So this is how to interpret X-rays in DDH. So this is in normal X-ray. You need many helpful lines which you will have to paint on the picture. And this is the normal side, and this is the hip dislocation side. You can see here, this is the line of the acetabular roof. So here you can see the acetabulum is, well, it's fine, is pretty flat. Here it's very steep. The angle is more than 30 degrees. Here the angle should be below 30 degrees. You can easily imagine that this acetabulum cannot hold a femoral head down here. Here, where should it go? You can't, there's no way it's blocked here. Here, there's no block. Yeah. And there's this is the Hilgenreiner horizontal line at the lower base of the acetabulum here. And also very important is the Shenton's line. Here is a line where you can see here, it's a nice curve. Here, this is interrupted. Here, you don't see this line anymore. But this is not, here you have a big there. So this is a X-ray film of one of the kids. Here, this is of course easy to see. Here, the normal side, nice acetabular roof, and this is the bone here. Here, not a nice roof, and of course you see the distance here. This line here, this line, oops, should go up here. It's not here. This is complete dislocation of this hip. The femoral head is somewhere up here. So the ultrasound is very helpful in the newborn up to about 6 months of age. And then the ossification center of the femoral head appears, and the acetabulum cannot be seen anymore. So from then, you need X-rays. I'll just show you the ultrasound technique as developed by Graf. This is really very helpful. I was so lucky, and I attended lessons by him himself 25 years ago. To be shown by himself how to do it. So you need to put the baby in a correct layer, how to place it correctly, so the baby cannot move. It needs to be completely vertical here. The arm is up here. Mom is holding baby's arm, so the kid can still move the head and can move, but he cannot move too much the leg. Then you hold the ultrasound head here and move it to and fro, and until you see this picture. And you need to have 3 landmarks to be able to interpret, to use the picture for measurement. If you don't have those landmarks, you cannot use the picture. So you need this echo. This is the lower rim of the os ilium. No, this is the lower rim of the os ilium. This is the straight echo. It needs to be straight and have the bow here, the bending. And you need the acetabular labrum. This here is the femoral head. Well, this is where the bone ends, the preformed bone ends here. This is where, because ultrasound cannot go through bone. So you need those three landmarks to be able to assess the ultrasound picture. And you have to practice a bit, move the head to and fro, and then freeze the picture, and then you can put in the measurements I'll show you later. So this is from his textbook, which I have. They are still old pictures, old quality. The textbook I bought about 20 years ago. Of course, they look much nicer now, but even with the poor quality from those films, you can still really assess it. So this is the picture of in normal paintings. As I showed you, this is the straight line of the os ilium. This is the lower end of the acetabulum, and this is the labrum. And here you can measure. This is the labrum, the lower end, and here you put in those lines. This line 1, 2 from the lower end here through the labrum, and 1 up here, and then you have alpha angle and beta angle. Most important is alpha angle. Of course, it's easy to see. The higher this angle is, the better is the roofing, the better the acetabulum. This here is already really bad. You can see this is about to slip out here. So here are, he has also a big gradation, is type 1, type 2, type 1A, 1B, type 2, 2-1, 2B. You don't really have to study that at the beginning, but this gives you a nice overview. Here you see the anatomic picture, where is everything. You see this on the ultrasound, and this is a nice hip. This is really nice to see this one, what you need this one, you need that one. And here, this is the anatomic correlation. Here, this hip is nicely in the acetabulum. Here, it's still looks good, but it's a little bit further out. The acetabulum is not as nice as this one. Here, you already see, here in the acetabulum, there's not a sharp corner like here. Still, this is a little bit round corner. And if you have paint a line here, this is not as nice as this here. This is an angle of maybe 60 degrees. This is already a little bit worse here. And if you look exactly and compare, you have the feeling that the femoral head is moved a little bit out here. But still not bad. Here, if you compare that here, the acetabulum walks. If you do the angle here, from here up there, this is pretty bad. This angle, the beta angle, is also too big. And you see actually the femoral head slipping out here. And here in this type, it's completely out. This hip is completely out. If you go back to the other one, if you have a look at this picture, remember this picture, remember this one, and compare to that one, and then you definitely do see a big difference. This is, again, from my English language textbook, also about the graph grading of DDH. He actually had some more classification, but here you can also see it here, the dysplasia, ilium, femoral head, capsule, and labrum. Here the labrum. And how you do these angles, the alpha angle, the beta angle, and the smaller the alpha angle, the worse, and the bigger the beta angle, the worse it is. So they have subtypes, which are not shown. This is not too difficult, too important at the beginning, but you see how easy it is once you've practiced a bit how to do it, how to find out and to really discern not just hip is in, hip is out, but the gradation about the degree of dysplasia. So this is an example from his textbook. This is really very nice to see. So have a look at that. This is newborn screening. Baby was born, was shown, sent to his clinic. So this is a type 4. He said, here you can see, this is the ilium, straight echo. This is the acetabulum, the lower rim of the acetabulum. This is the labrum, and you can see this hip is completely out. This is a type 4 hip, complete dysplasia. This kid is now 1 week old. He was treating it with 3 days overhead extension. So the legs were like hanged to loosen those contract structures. Then he got this kid got 3 weeks of a speaker cast, 3 weeks speaker cast. But now this kid is 4 weeks old. Look at that. You see here, this is now really much better than this one. So it's still not very good. You still have a round acetabulum. You can see the lower rim here. The labrum is here, but this looks already much better than this one. So he got another, like a Pavlik bandage for 4 weeks here and for another 8 weeks. And this here at the end of treatment, this is a complete normal hip. Complete. And this is just now the kid, baby is here 3 months old, 15 weeks, 3.5 months. And this is the x-ray, corresponding x-ray. If you don't treat this one, age 1 week old, you will never ever get this x-ray just 3 months old. No, this is 10 months old. Sorry for that. This is 10 months old. This is age 3 months old, but this is already completely normal. If you just wait for the x-ray, age 3 to 6 months, you miss all this stage where you can easily treat them. So what is the treatment? Treatment is reduction. As he did here in this picture, you need to put this hip back in. You need to loosen the structure. Most of the time you can get a closed reduction. Sometimes there's things preventing closed reduction. You need to do open reduction. This is very, very rare. And then you need retention. You need to keep the femoral head in the acetabulum. And then you need the treatment of the residual deformity, dysplasia. So the earlier treatment starts, the less effort is needed and the better the results are. So I really think all newborns should be screened like week 1. It doesn't harm them. It does not hurt them. It's such a harmless method, and you can so easily treat them. So reduction closed is possible, open if necessary, very, very rarely. Retention in a cast or a splint, depending on how bad it is. And the principle of the cast and the splint is flexion and abduction, and thereby centering the femoral head in the acetabulum. And this leads to the maturation of the acetabulum to the development of a normal acetabulum. So the aim is a concentric reduction and the normal anatomy. So this is a proper, like the Pavlik harness, very commonly treated. How you should put the baby in, and all the time they are pushing against this. They're pushing their hips into the acetabulum. So this is actually developing the pressure of the baby into pressure on the acetabulum. So this is a very clever device. And the younger the kids are, the less they are harassed by that. As they're as young as that, they completely ignore it. They don't even realize it because they're just being awake, being fed, sleeping in the first 2 months anyway. And you can carry them around with it. So this is really helpful. And if you need it for only the first 3 months of their life, problem solved. It's much easier than to put it back on later. This is a speaker cast. If you have to put a cast on, this is what it looks like. Also, abduction, flexion here, 80 degrees. You need to avoid flexion of more than 90 degrees on the hip joint. I'll come to that later. So what happens if you miss it? If you have to see it later, then it starts to get really complicated. You need to correct it surgically. Surgical correction in case of late diagnosis or if you have a neurological condition. So what you can see here, a lot of different procedures. You don't have to study them if you don't want to do pediatric orthopedics. The most common used is the Salter osteotomy, and sometimes in combination with a varus femoral osteotomy. The aim is to make a congruous hip joint by you push that down here you have to form an acetabulum, and here you make a varus out of too much valgus. It depends on how bad it is and how old the kid is, which osteotomy to use. If there are so many different techniques, that means the perfect solution hasn't been found yet. Also, you can see here on those pictures, please don't study those by heart. Those decidograms, as I like to call them, so suspicious finding birth to 6 months. Abnormal physical examination, imaging here, 1 month ultrasound, 2 to 3 months pelvis x-ray. As I told you, we are not just doing it for abnormal physical examination. All kids get an ultrasound. It's not expensive. It doesn't harm them. And then you have the diagnosis. If it's reducible, pelvic harness, stable 4 to 6 weeks. This is the normal thing. A radiograph normal, everybody happy. This is the normal and most common thing. If it's teratologic, of course, and it's fixed, then you have to do something else. But even those you can usually treat conservatively, and you do a pelvic osteotomy even in babies. So screening limb 6 to 18 months, you see much more complicated. And here 18 to 30 months, even more complicated. And here you already see this is not a really positive smiley. This is not very nice. So the results are not that good if you start treatment later than if you start here. And even worse, abnormal exam link 30 plus months. It's lots. It always leave unreduced. Surgical procedure, and this here does not look happy at all. So those are the different types of surgical corrections. Please don't study them all at all. What you need to learn from this is start treatment early, and you can avoid all those nasty things. Age 6 to 3, one operation, another operation. This is not nice for kids. And sometimes it's not working, then they still need hip joint replacement. Age 20, already have a lot of scars, in and out of hospital. You can prevent that by studying the ultrasound. Like I said before, look at this. This would have been disaster if not detected and went on to completely resolved. So what are the complications of treatment? Complications of treatment are avascular necrosis. If you have too much abduction, in the speaker cast, if there is too much abduction, you can get avascular necrosis. So this should definitely be prevented. And as I said, results, the earlier treatment starts, and the better the results are. So early diagnosis is definitely desirable. So if I can motivate just one of you to study grafts, ultrasound technology, it's really very rewarding. What is the take-home messages from today? Don't miss tumors. Main factor, pain at night. If a kid complains about pain at night, it might be tumor. It might also be what is it called? Something not that bad, but pain at night always needs, have a closer look, do x-ray, do CT scan, do take it serious. Don't underestimate the effect of growth in both positive and negative consequences, and maybe consider learning and studying hip ultrasound. Thank you for your attention. Here is the sources. This is the guy who developed this technology, and there's also a lot on the internet. I have some internet addresses where you can study. Mayo Clinic has some things. So thank you very much for your attention.